much for coming today, taking time out of your solar eclipse viewing to come to today's supplementary seminar. This is co-hosted by the Department of Community Health Sciences, Neil Bryan Institute for Public Health. I'm Paul Rumsley, an associate professor from CHS. I'll be today's moderator and just introducing today's speaker. Before we start, I'd like to pay tribute to the traditional territories of the people of Treaty 7, which include the Blackfoot Confederacy, comprised of Siksika, the Kainai First Nations, the Pina First Nation, and the Stone Dakota, Chiniki, Bearspaw, and Goodstone First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. We're all very fortunate to live and work in this beautiful land. So for today's event, I have the pleasure of introducing one of my colleagues, Dr. Dan Kobewka. Dan is a clinician scientist that works at the Ottawa Hospital. He completed his medical school training at the University of Alberta, Edmonton, followed by internal medicine training and a master's in epidemiology at the University of Ottawa. On a personal note, I've known Dan for 10 years. He was doing his master's. I was doing my postdoc in Ottawa. We were both supervised by Dr. Alan Forster, and we'd sit in this little office together in the administrative services building, kind of spitballing different ideas, but most of the time just kind of figuring out what the heck we're doing with our lives and probably just really not knowing exactly what that looked like. But at the time, Dan started a research program that was focused on end-of-life care and medical decision-making. And that's grown a lot over those last 10 years. And so today he's going to be talking about what his team's been doing in that space. And so join me in welcoming Dan up to the podium. Thanks.
Thank you so much. So nice to have all these people to speak with. We were concerned to be only online, so it's nice to see everyone here. I think it's a nice introduction, Paul. It's very kind. I can actually change slides. So, how do I think we just go back. There we go. Yeah. Oh, we're going forward. See that again. Yeah, it's like, oh no. Getting too much of all our presentation. I'll have to keep the suspense. Right, so this research is funded by CIHR, a CIHR team grant. This is our team, a large team made up of patients, long-term care clinicians, decision scientists, statisticians, geriatricians, palliative care doctors, among others, postdocs, long-term care administrators. And no conflicts of interest. So the objectives for the talk, I'm going to talk about 45 minutes, and we'll have some time for discussion and questions. I'm going to describe patterns of functional and cognitive decline among long-term care residents, examine the harms and benefits of hospital transfers for older adults with frailty, and describe the decisional needs of healthcare workers, residents, and care partners who participate in decisions about transfer to hospital. So our team vision, every time we have a team meeting, every week or two, when we're discussing new data, we always ground ourselves with what we're here to do and what our team is focused on. So just going to read this to you. Our team vision is that every transfer from long-term care to the hospital benefits the resident. We want residents, family caregivers, personal support workers, nurses, and doctors to be informed and supported to make resident-centered transfer decisions. So I use the word frailty throughout this talk. I just want to define that term up front, so it's we're all on the same page. So frailty is a clinically recognizable state of increased vulnerability that resulting from aging associated with decline in reserve and function across multiple physiologic systems, such that the ability to cope with everyday or acute stressors is compromised. We see this, we see frailty in long-term care all the time. The way it plays out in real life, if someone gets a simple illness, perhaps a bladder infection or pneumonia, and their function often takes a step down, as it does with most of us, or all of us when we get sick, right? You're in bed for a few days, you're not feeling well, and most or many long-term care, people who live in long-term care who have frailty don't recover. They don't bounce back. So there's often a prolonged and incomplete recovery. For many people who live in long-term care who have advanced frailty. This is often shown, you've probably seen it before, people love to show this, because it lines up what we often see clinically, of different ways that people's function decreases up to death. So what does function look like before someone dies? Sometimes people die suddenly, sometimes there's a terminal illness like a metastatic cancer, it's the most common, organ failure, people with heart failure, or COPD. And on the bottom right is frailty. And this is what we see among many, not all long-term care residents, but among many of them, where there's a decline in function that is low and goes on for some time. So why am I talking about this? This is all context. So what are the goals of care? Often when we talk about a transfer to hospital, I said that our team's vision is to make sure that every transfer benefits the resident. And so what's the definition of benefit? What is benefit? What does that mean? And the way that we think about it is it benefits the resident if it pursues one of their goals. If the transfer helps them pursue something that's meaningful and important to them. And within in terms of what goals medicine can actually accomplish, there's really only three things that medical care can accomplish. It can help you live longer, it can help increase your function, and it can help reduce symptoms. And every individual has a whole personal story attached to each one of those. Well, why longevity might be important for them, or what elements of function is important. So this is a very personal thing, but at a high level, there's only these three main categories that we can help people achieve. People have many other goals in life, but what can we achieve with medical care comes down to these three things. So how do these goals influence medical decision making? And as our team has been thinking about this and how we answer some of these questions, how we better support everyone, we've really focused on those three goals. There's a lot of data out there to help support decision-making about mortality. There's many treatments we think about are measured in terms of mortality benefit. So antibiotics for infections, orthopedic surgery for hip fractures, catheterizations, cardiac catheterizations for STEMIs. You go on, make the list. Mortality is such a wonderful outcome because it's so black and white. We can all agree on what it is. It's easy to measure. There's no subjectivity to measuring mortality, which as an epidemiologist is great. But what we're often missing is data on these other outcomes. So to advise someone and give a family member or a resident good information about what lies ahead for them, we often don't have a lot of data about what functional outcomes could look like or how symptoms can be managed. So our team, in looking at the long-term care data, one of our first goals for our data analysis was to bring some data to the functional outcomes and say, well, which functional outcomes are important? How can we define them? And can we give people and caregivers and doctors some confidence by showing what happens with these outcomes? So our team is large. We also have a patient family advisory council that advises us. And we looked at the data we had available, met with our patient family advisory council, as well as the multiple experts within our team to come up with 4 outcomes that we thought were important to patients and caregivers, important for decision making, and that our data could actually support. So these 4 outcomes, the first is severe cognitive impairment, which is defined as rare or absent ability to make decisions for oneself. This was probably the most important one in talking to patients. When we talked with patients about future outcomes, they said, living longer, thinking back to those goals, living longer is really important to me, but Breathe along is really only important if I'm making my own decisions. We heard that from a lot of patients. So this was, that was a key element of quality of life for many of the patients that we spoke to. I just want to pause here and just to clarify something. As we talk about these outcomes, these functional outcomes that are really states of severe impairment, none of this research or none of this outcome definition is intended to value people more or less based on function. That is not the purpose of this. And I think that's partly why this is sometimes hard to talk about. What we do want to do, though, is say, here's the reality of how function can decrease. It does decrease for many near the end of life. And we want to just openly share that with you. It's up to the patient, it's up to the family to decide what that means. This is not our decision, but we want to share this information openly and have, be transparent about what this looks like. The next outcome is severe communication deficits, so inability to understand others or make yourself understood. Severe functional impairment, so total dependence on others for all physical care. And then lastly, incontinence, so bladder or bowel incontinence. So our quantitative analysis has taken 2 steps so far. The first being a descriptive work, just describing these outcomes over time among long-term care residents. And the second part, looking at the role of hospital transfer. So does hospital transfer change these outcomes? Can we say that transferring to hospital makes these things better or worse? So the data sources for both these analyses is multiple linked data sets from Ontario held at the Institute for Clinical and Evaluative Sciences. The main data source is a survey that's done in long-term care called Inter-Eye Long-Term Care Facility Assessment Instrument. This is a really in-depth survey. It is 260 some items. It's performed on admission to long-term care, and then every 3 months thereafter. It's also performed as an acute change in the resident's health. This is also done in across Canada. It's not unique to Ontario, and it's used to measure quality of care within long-term care homes. It's quite a burdensome thing for that long-term care homes to be measuring this, but it is also a very rich data source because it has rich data not just on medical comorbidities but on function, agitation, depression, many other outcome scales. For our descriptive, for both of these analyses I'm going to be showing you, the data set is the same data set. So it's a retrospective cohort of adults who are over 65 years old, entered long-term care homes between 2013 and March 31st of 2018. Each person had a minimum of 5 years follow-up, unless they were censored. So had been discharged or had died during that time. The final data in the data set is from April 1st, 2023. There's 120,000 some individuals in the cohort. This is just some baseline characteristics. I've just abbreviated it with just a couple slides just to give you an idea of who these people are that are in long-term care. So mean age at admission, 84 years old, almost 65% female. Cognitive performance scale. This is a measure of cognitive impairment. And this is, once again, this is at the time of admission. So intact is 15%, moderate impairment, 34%. And there's very few who have severe or very severe impairment, about 9%. This is the ADL self-performance hierarchy scale. So a measure of ability to perform activities of daily living, dressing, bathing, these sorts of things. And most people at the time of admission require a lot of support. So the categories of limited, extensive, and maximal account for most of the cohort, and then a few in the dependent and total dependence categories. And lastly, chronic conditions, just a few key chronic conditions. 58% have dementia at the time of admission to long-term care, 18% stroke, diabetes there, Parkinson's disease, and multiple sclerosis. So this figure is a little bit difficult. I'm going to just explain it. My laser pointer, I'm not sure if it's working very well, but it's not. I'll just discuss it. So at the left-hand side of this figure, we have the prevalence at the time of admission of each of these outcomes. So the black line starts at 0, meaning that no one was dead when they were admitted, by definition, obviously. And then it's a cumulative incidence curve as time goes on. So you can see that by along the x-axis is the assessment numbers. These assessments are done every 3 months. So every 90 days. So we have a 5-year period along the bottom in 3-month increments. So you can see that mortality over time, by the end of 5 years, almost 75% of the cohort has passed. And then each of the outcomes, so looking at incontinence first, at admission, about 23% have incontinence at admission, and that slowly climbs over time. In brown, the next one, so CPS more than 5, this is severe cognitive impairment, inability to make your own decisions. It's about 9%, and it slowly climbs over time. ADL equals 6 is functional impairment. It's the same story, so slowly it's low at admission, slowly climbs over time. And lastly, communications, inability to make yourself understood or to understand others, slowly climbs over time. The next question is, looking at these outcomes, saying, okay, well, these outcomes happen to a significant number of the people living in long-term care, but are these outcomes just part of the dying process? Or do some people live in these states for a long period of time? So each of these, these are Kaplan-Meier curves of survival once people have entered these states of impairment. So, for example, on the panel A is cognitive impairment. So once someone has entered the state of permanent cognitive impairment, severe inability to make their own decisions, how long do they live for in these states? And as you can see, for many people, having severe cognitive impairment is really kind of part of the dying process. Many people pass within a few months of being in that state of disability. And then there's a long survival tail. So there's many people who live for years. There's about 20% of the population that lives for years with this level of severe impairment. And the story is the same for each of these outcomes, that for many people, it's part of the dying process. And for a subset, or a group, they live for a long time with these disabilities. We wanted to know if it was the same story for people who are older and younger, and those with dementia, without dementia. So is this, with a few key subgroups that select for more frail people, is this a story of frailty, or is this, does this apply to all people in long-term care? So maybe, I guess, the people who live for a very long time, maybe they're very different. Maybe that subgroup is living for a long time with severe impairment. Maybe they're much younger. Maybe they're a very different group. And the short answer is no. This here is subgroup analysis looking at those over 80 and under 80 at the time of admission. And even though the curves are different, people who are older have a higher mortality risk. We know that. The curve, the shapes are not different. It follows the same shape, and it's really the same story. The same question for those with and without dementia. This one was a little bit, I guess this was surprising to me, but in retrospect, it makes sense. So those who have dementia here are in red. So dementia at the time of admission. Many develop dementia throughout their stay in long-term care. And those who had dementia on admission, actually, the shapes here are actually different. They actually have a longer survival and don't have that steep drop off in the first few months. I think it comes back to our frailty trajectories. This is because dementia is an illness where people die from that frailty trajectory, and it's just a slowly progressive. Whereas others without dementia are more than will be dying from trajectories that have more sudden drop-offs in function, such as malignancies, other causes of more sudden death.
That's actually a question about the dementia.
Of course, yeah.
What do they have in severe cognitive impairment?
To have severe cognitive impairment and not have dementia. So complicated to go back and see. I'm not gonna. Darn it. I did this last time. Are you able to? I don't know why I can't do so. So the folks, all the folks who had severe cognitive impairment would have had dementia. The two different lines were whether they had dementia at the time of admission or not. So it was dividing, looking at the subgroup who already had dementia at the time of admission and those who did not have dementia at the time of admission. And then follow them forward. But you're right, once they met the criteria for severe cognitive impairment, they would have all qualified likely as having dementia. I realize that's not clear.
Yeah, so I'm not really sure what you're showing to them.
Yeah. The subgroup that we're showing here is dementia at the time of admission versus not. So I guess there are some people who are in long-term care who have care needs for other reasons, not due to dementia.
Well, there's also an huge underdiagnosis of dementia.
There is, and
That's probably what you're thinking of.
this is a data problem, of course. With any administrative data, it's not perfect. The question we're trying to answer here is people who had high care needs for other reasons, not related to dementia, perhaps related to mental health. We would expect these people to have a longer survival and live in these states of disability for a longer period of time. So we're trying to understand if there was if we could at least look at partition by frailty, looking at using dementia, using age, and using dementia on admission to see if this is really a story of frailty or if it is if the whole population is the same. I realize it's still probably not clear. Can I come back to that as
Yeah, because dementia by definition, severe dementia, severe frailty, right? Like
yes,
by definition, right?
yes. This is stratified at the time of admission, not and then followed over time. So it's really just the admission diagnosis of dementia that's shown here.
Sorry, is dementia diagnosis comes from administrative data, but not the inter-RI, right?
It actually does come from inter-RI. We use the inter-RI definition of dementia here also. So these people who did develop dementia, but did not, the ones in blue here did not have dementia on admission, but then later met the
Well,
criteria.
I think your severe cognitive impairment, you're using the inter-RI data, but is your dementia not an actual official diagnosis of dementia?
No, we use the inter-RI. There's lots of ways we could have got it. We did get it from inter-RI here.
Didn't you use the RI cognitive screen to determine severe cognitive impairment as well? Right? Is this the RI that you're saying you use the RI dementia screen for dementia as well? To use the same tool?
No, so we used we used the comorbidity list from the RI.
They have to have a diagnosis of dementia. They're listing the comorbidity diagnosis. So what you're picking up is the lack of diagnosis of dementia on the presentation, which is well known.
Yes. We say it again, sorry.
So the tool you use to figure out severe dementia is there's a tool on RI that actually assesses someone's cognitive. Like
Yes.
It's usually a nurse that does the assessment is picking up, right?
Yeah.
So that's your severe cognitive. And I think the RI tool you're saying used your dementia is just when they enter the diagnosis of the patient.
Correct. Yes.
So what you picked up, all you picked up is that there's an underdiagnosis of dementia of presentation to long-term care, which is actually wrong.
This I don't want to. I want to answer that one. I guess I'll say one thing and we'll move on. And I'm happy to talk about after. I don't think this is only survival. So how long someone lived after they entered that state of severe impairment. So the time at which these people enter this state of severe impairment is different. It was all over the map. So they're admitted, and we have two groups, those who are admitted and have that diagnosis on admission, which I agree is underdiagnosed. It's not, there will be many people who are misclassified. And then once they enter the state of severe impairment, we just look at survival. How long they lived once they were in that state. So once they were in that state, yes, they all would have met the criteria. Those who had the diagnosis on admission have survived longer and had a more gradual their survival curves are more gradual. So our next question was, does transfer to acute care hospital increase the risk of severe impairment? This is a really hard question, kind of impossible to answer actually, but it's often a question that's important because when someone is sick, often long-term care, they may have delirium, they have a fever, they stop eating, whatever it is that happens. There's a decision that has to be made. Should this person be sent to hospital? And if they are sent to hospital, what are the harms and benefits of that? Are we going to improve survival? Could we worsen their functional impairment? The reason this is somewhat impossible to answer is we don't have the data on all the confounders at the time of transfer. We have all their comorbidity data and we can build models to adjust for all of that. But we don't have data on what was happening at the time of transfer. And transfers, there's always some human judgment there. There's some engagement with the decision, and we were missing that data. So for this analysis, we looked at the exposure of any transfer to the emergency department. We looked at 3 outcomes. So subsequent, the same outcomes we just described, the subsequent new permanent functional impairment, subsequent new permanent cognitive impairment, and all-cause mortality. We only measured outcomes in the period immediately after the person was transferred. Because there any causal link between the transfer and his subsequent state, you say, well, if it's related to the transfer, if there's some relationship there, it will only happen that we can only be certain that there's a causal, or more certain there's a causal relationship if it happens in the assessment period right after they come back from hospital. We wanted to explore the possible causal association. So we used 3 different model types. We were not looking to nail down the hazard ratio and say, oh, is it 0.1 or 0.2? We wanted to just understand overall for the whole population, is hospital helping or hurting for each of these diagnoses? The 3 models we used first was a cause-specific hazard model with time varying exposure and covariance. This is kind of like standard epi. We next used a marginal structural model with time varying exposure and covariance. Marginal structural models account for relationships between variables that change over time. So it allows for the relationships to vary with time. And lastly, we use an instrumental variable design. For the first 2 models, we know that we have a huge piece of unadjusted confounding. We know that everything that happened at the time of transfer, the illness that the person had that actually led them to hospital, we don't have data on. So we know that it's going to still be confounded. The instrumental variable that we had a lot of discussion about and that we used was the preference of a long-term care home to transfer someone. So there's a huge variation in how many residents a long-term care home transfers. There's actually a 7-fold variation between the long-term care homes that transfer a lot and those that transfer a little. The patients in these homes are very similar. So the age, the comorbidities, all the other patient characteristics between the homes are actually the same. And a lot of the difference in transfer rate has to do with culture, proximity to hospital, availability of resources. It's a cultural phenomenon that is not directly related to the outcome. So just briefly, and I can come back to this, but so what is an instrumental variable design? It's an instrument that's used to mimic randomization. So meaning that there are some individuals who would be transferred if they were in home A, and if they were in home B, they would not be transferred, even though everything else was exactly the same. And the difference, whether they're transferred or not, only has to do with the preference of that home to transfer. If they're in a high transfer home, be transferred. If they're in a low transfer home, they are not. There are other individuals who would always be transferred, and other individuals who would never be transferred. So the instrumental variable analysis only applies to the residents where the transfer depends on the preference to transfer of the home they're in. The nice thing about it, what we can do with it, is it allows us to adjust for unmeasured confounding. And as I've said, we know there's unmeasured confounding because all the patient characteristics at the time of transfer, we don't have data on that. So we use these three different analyses to look at the population level and say, is transfer helpful or harmful for each of these outcomes? So for each of these outcomes, the cohort was slightly different because people who already had the outcome of baseline, of course, were not included. So for functional impairment, 116,000 people, of whom 57,000 had at least one transfer, and for cognitive impairment, 109,000 individuals, and 52,000 had at least one transfer. Does not show up well. Hey, those white letters on the gray. Apologies for that. So the incidence of new permanent impairment and mortality by transfer rate. So among those who are transferred, these are just crude levels. This is not adjusted at all. But new physical impairment is much more common. So incidence of 20 per 1,000 person years. For cognitive impairment, it's 25 compared to 11 for those who are not transferred. And incidence rate for mortality is 82 for those who are transferred versus 37 for those who are not. So this is expected. Is the reason someone's transferred is that they're unwell. Something happened to them if they're unwell. So good sanity check. The data makes sense. So for new permanent physical impairments, this is complete dependence for ADLs. We adjusted. So first, the crude model is a 2.9 times as likely if you're transferred. This is unadjusted, once again, as expected. In the adjusted, in the Cox model, the marginal structural, and the IB analysis, the point estimates for all of them show that people are more likely to have new physical impairment if they are transferred. Now, we expected absolutely the two models that were incompletely adjusted to have hazard ratios above 1. But the IB analysis, even after adjusting for unmeasured confounding, still found the hazard ratio point estimate above 1, meaning that if the transfer is discretionary, someone is transferred, there may be increased risk of having new functional impairment after coming back to long-term care. Now, the confidence interval crosses 1, so we can't be that confident about this. And this is a feature of instrumental variable analyses. They have wide confidence intervals. So all the analyses point in the same direction, but the most adjusted model, we have a confidence interval that crosses 1. Looking at new cognitive impairment, the story is not quite the same. So the crude effect is that, yes, if someone's sick and they go to hospital, they're more likely to have new severe and permanent cognitive impairment. But in all of the adjusted models, they all hover around 1, with the less adjusted model showing a protective effect of hospital, showing that hospitalization is protective. But in the most adjusted model, once again, it's maybe protective, although the confidence interval crosses 1 again. And then lastly, Lastly, for mortality, the hospital is really built to keep people alive. So what hospital does best. And when in the less adjusted models, so the Cox model and the marginal structural, we find that there's still an excess risk of transfer. But once you adjust the unmeasured confounding, hospital is very protective, which is good, because that's what hospitals intended to do. So in summary, the takeaway from this, for me, is that hospital prolongs life, which is great, because that's what the whole hospital is set up to do. And there is some evidence here that after going to hospital is more likely to leave someone in a state of severe impairment. The evidence is not conclusive or strong, but there's some evidence. The difficulty with this, or you can say, well, this is a useless analysis. This is population level. Everyone's an individual, and transfer to hospital is not an intervention. It's 1,000 different interventions, right? They go for many, many different reasons. So to say to look at the population level, this doesn't necessarily help us form decision making. It just shows what's happening at the population level. And I agree completely. So that's our progress with the analysis. The next steps that we're working on is looking at some of those cause specifics. So instead of saying transfer in general, let's look at specific causes of transfer. Specific causes that are actually actionable by long-term care home staff. So things like going for a fever, going for delirium, going because of a fall with a skin laceration. Because these are not the same things, and they're going to be very different harms or benefits. Along with this work, the overarching purpose here is to bring evidence to the bedside to help inform decision making and support these decisions for everyone who's making them. So we have also engaged in interviews, a decisional needs assessment of all the stakeholders in these decisions. Our research questions for these interviews is, what are the experiences of residents, care partners, staff surrounding decision making about transitions from long-term care to hospital? And what are the staff, residents, and care partner priorities for a decision-making tool that they would feel would better inform, support, and engage them before and during decision-making process regarding transitions from long-term care to hospital? These interviews, we have partnered with 3 long-term care homes in Ottawa, so Gruyere, Early Health, and St. Patrick's Home. The study design, we use semi-structured interviews with residents, care partners, and staff who have experiences in long-term care to hospital transitions. I have a few interviews left to do, but we're almost complete. A few left to analyze. So far, we've interviewed 8 care partners, 10 staff members across different staff member roles. So RNs, RPNs, personal support workers, as well as physicians and directors of care, and 9 residents. We have found six themes, or one overall overarching theme with 5 sub-themes that come out of our data. First is communication. So effective communication is a cornerstone of decision-making, collaboration, and advocacy. It ensures patient-centered approach, fostering understanding, autonomy, and better outcomes for residents, families, and caregivers. I find within qualitative work, you read the theme and you might say, oh, that kind of makes sense, but it's really the quotes that make it come alive and bring, really give you an understanding of what this is really about. So I'm just going to read the quotes for the next few slides, just to illustrate each of the themes. And what I told you earlier, it's very important to make residents understand why it happened, that he could go to the hospital because they often go to the hospital. They're told to be transferred to the hospital, but sometimes they're not given an in-depth explanation of why that was the last resort. Failure in communication at times. Next, something, access to information to make informed decisions. So the quotes here are, that's usually a gap, right, for families, is that they actually don't know what we can do here. They don't know what we have. We don't know that we have the resources for managing dementia, delirium, depression, or that we have resources to manage an acute health event at the end of life. Next quote, because we don't educate the nurses on what we can do here, they'll often support sending to acute care. Past experiences shape transition willingness. I've had a few problems with my heart. The ambulance came. They wanted to take me, but I said, I've heard so much about what goes on in the hospital. They'll just put you in the hallway. Patients had to come right back here. Really, all my experiences going to hospital as of late have been reasonably positive, as long as you bring the book. That was true, a little fun. Revisiting care planning processes. Quote here, there was no preamble. Like this was supposed to be my care conference, and I had looked at my chart. There were some changes I wanted to make, but the focus, at least from the point of view of the doctor, was on my last wishes. I've been thinking, well, I just got here. As far as I know, I don't have any, the health problem that took me to the hospital initially is all cleared up. I haven't heard anything else that I'm, on my way out. But the focus, expensive focus, was on my last wishes. I found it disconcerting. I found this quite powerful because it's kind of in my experience to focus on decisions around end of life without focusing on the whole person and focusing on life now is very of course it's disconcerting. They're a person who's living to sit down and say, okay, do you want to go to hospital or do you want to be have palliative care in the home? It doesn't make sense. It's not it's scary and it's not focused on what matters to them here. So I would focus on living now is a much more seems like the right approach as opposed to these sometimes scary decisions that may come or eventually come. Skill building for long-term care staff to support transition decisions. I have a lady who's at end of life with some complex diagnoses, some complex symptom management, and we call it a comfort care round or palliative care room. Sit down with teams so they understand how we can manage. So it's also my role as educating the nurses and mentoring them so that they also have that knowledge and skill and how we can manage this acute care here because they're scared. I thought that last line is very telling because they're scared. Which makes a lot of sense. That's really a natural reaction to a scary situation if you feel unequipped to provide the care that this person needs. So the next steps for our team are to create predictive algorithms for severe function and cognitive impairment. My hope is that the reality is in trying to predict these outcomes or really any outcomes, the best you can do is have some probabilities. And probabilities are not easy for people to interpret. Communicating probabilities to patients and care partners is very hard. It's very hard for them to integrate them into decision making. So to talk frankly, I think that predictive algorithms could be useful, but really the goal here is to shift the conversation. Say this is not just about how long you'll live, but it's about how you live and what your function is and what's important to you. As I mentioned, we're also going to explore outcomes from transfers for specific causes, so cause-specific transfers, because this look at all transfers, it's a mixed bag. It's not one thing. And then this summer, we're starting co-design workshops with long-term care staff and residents to create tools and processes to address decisional needs that we've identified in our needs assessment. That's all I have. I love it. If any questions or comments, wonderful. Thank you.
Great, Dan. Any questions in the room for Dan? Dana?
So there is a group in the States called the Interact that have developed a whole bunch of tools. We've actually used a lot of them in the Canadian context with good success. Here we just did a project to look at the transfers do long-term care and ED, and we use these interactions and pick up an acute quick decline sooner, because it picks up that the presentation is often atypical with this patient's frail and complex comorbidities. And then it gives time for the facility to actually, involve the long-term care doctor, make some strategic decisions, and then have a discussion. We implemented this across Calgary, including, and then also used our rapid, which is basically a facilitated discussion between the long-term care physician, long-term care nurse, and the ED physician before transfer. Have a discussion, unless it was absolutely emergent transfer that must happen. If it was not, we would have a conversation and we give information, because that's also a very in these transfers, right? It's not patient, so we talk about the patient and what was the reason for transfer, what did the emerge need to do, and then the emerge physician ideally would be the physician that would treat the patient when they arrive. Implemented other strategies sort of along the way, but that was the main thing was around. Oh, and we use community paramedics, although because we implemented the study during COVID, the community paramedics didn't turn out to be a huge resource, but so we're actually the papers just manuscripts just out, and we did some really qualitative interviews with sort of what the decisions were, and they're all out for publication, but we did show that if you actually do that, if you actually pick up changes sooner and you actually have conversations, you actually decrease rates of transfers successfully. No, we actually just established so that's not right. So there's a fair number of these interactions are very useful. We've used them in other settings too, in terms of not needing to start over, but there's lots of resources out there that they and it was designed by geriatricians in the US that are actually working in this context. So I encourage you to look at that. They interact. And they actually cooperated with us. They adapted some of the tools we wanted to use to the Canadian context for us. So, so they bought some of these tools. I don't know if others want that. Similarly, I see we did Sharon Cass about this guy.
Yes,
So we looked at also there's been a purpose. We looked at palliative care within long-term care. She's just one too. We looked at that to support other barriers. So there's a fair bit of literature out there already around a lot of this, and also Ken Kaminsky in the US has done a lot of stuff looking at what happens to the population going to hospital, and right, it shows that third will decline in function, and when you do decline in function, you take a chance to recover. So some will recover, but most do not. So I encourage you to kind of be kind of ready to look at, because there's a fair bit of literature around a lot of this before you start developing between this, in terms of right and understanding the limitations. The biggest limitation to this is your data, right? You're right, raw is better than a lot of data, but making up to learning is impossible, right?
Yeah.
A lot of these other right. So we're also implementing a frailty pathway. Continue care long-term care here in number. That's something that we pick up who's frail and implement appropriate strategies in the care pathway early on. So just figuring out, getting the nurses to actually figure out the although you can use it to ride, but there's limitations. Yeah. So we saw our other RCs do a lot of that. So encourage you to kind of reach into some of that. You have some of the geriatricians that do, but there's a lot of geriatricians that are working in this space across Canada. So I think that give you some input into where to go from here, because sort of reinventing the wheel.
Yeah, 100%. Yeah, no, absolutely. No need to reinvent the wheel whatsoever. I guess this project is interesting because part of it is like a local implementation project also, right? Even though barriers are common, but also each home has its own unique barriers, right? So it's that engagement up front, I think has been helpful in listening, right? And building trust and relationships. The tools you refer to, yes, I have seen them. I have looked at them. A few other comments briefly. And in terms of the early identification, yes, it's always difficult. We've been using an algorithm we call RESPECT. It's a mortality prediction tool based on inter-ride data. And we have about 8 homes that have implemented it. That just pops up on the physicians, and the physician logs in. It's a Google Chrome extension that gives them a mortality risk prediction. And We don't, the doctors like it, but it's linking it to action is still the next step. What you mentioned about actually picking up the phone and calling the doctor in the ER, it's brilliant, right? It's so simple. It's just like, it's so simple, it's obvious. But that communication piece is lacking so often between the care settings, and that's where all this much risk in having the wrong treatment when they don't communicate, there isn't good communication.
So the best interact tool is to stop and watch, which the healthcare aides do, because the healthcare aides, long-term care, the healthcare aides are the ones that are spending every day, like, day to day, everything moment to moment. And it's not the physicians, right? The physicians come in a few times a week, so, and that tool, I don't know if Vivian is on it, but that tool has been very powerful for helping, and it also gives the healthcare aides the language about, like, instead of just sort of going to emergency saying, I think the person is different. It actually gives them the language, a tool of communication for them. And then there's another tool that the nurses can then use to try to figure out what's actually going on, is changing condition. So I think those two tools in the Canadian context have been most helpful. And also implemented in this pathway. We also implemented in our support living to show the tools of more helpful in person. And overall, the interesting thing, at least to me, we just published the data looking at transfers during COVID, the different ways across Alberta, and actually the rates of transfers between long-term care and ED are dropping.
They were dropping before, like without COVID, they were just really off.
They've been dropping pretty, and throughout COVID, they continued to pretty much, there was some impact of the waves, but not really, so we just published that on the show. You know, what happened, what's happening in terms of transfer. Long-term care, they can do at least across all of Alberta. Data.
Interesting, yeah, what was behind that? Like, what-
And we looked at it by C-test. So it was not, I mean, the ones we're getting the you know, based on, it was sort of the middle range C-test scores. It's all most department.
No questions.
When we talk about long-term care, can Alberta we have long-term care, they have supported living? Are we including these supported living facilities or Ontario's organized, but is there a different gradation?
Yeah, I probably should. Yeah, that's a good question. So long-term care in Ontario is the highest level of support. So it's people who need extensive support. All the care, and the only publicly funded care homes we have in Alberta. If you have, like you said, you have to have a lower level of support available in Alberta.
Yeah, I mean, I think sometimes they, you know, when it comes back, my sense is that often the higher levels of supported living, they may need above residents there that may be actually comparable to long-term care. Depending where the long-term care center is, like that. Some residents of long-term care are lower needs than some. Not very.
Yeah, I think the long-term care population across the country is probably similar because it all is subsidized, higher level, you have to be help with the basic activities of daily living. But you're right at the levels in between, so Alberta has all these other levels for living. And then you also complicate it by private. You could actually be in a private assisted living and be the level of long-term care, so that gets muddy when you start analyzing. And in Ontario, it's called retirement. And then the level, it's just like here, right? The amount of care somebody gets within that level is variable. And there's also, you know, who's looking after them is quite different. So I think though, if you've just looked at long-term care, it's pretty, because it is the one that is subsidized, and it's better. But you're right, your supported living level 4 and long-term care. When you look at the patient populations, they don't look, and if anything, there's more dementia in supported living. Then yes. So yeah, it's.
Yeah.
Probably though, the data he's looking at long-term care to be comparable to our. Yeah.
If we got data for long-term care just because of legislation, we don't get.
Well, the study we did here was long-term care. The main reason is because supported living allows you to keep your family doctor, which makes it very hard to implement any kind of care change because you can have hundreds of family doctors in a large facility, right? Versus a long-term care, they have to, there's physicians assigned in long-term care. So it's much easier to do implementation when you have a, you know, relatively easier to engage in. You know, but I don't know, I think suppose similarly. On Ontario retirement, you can keep your benefit out. That's where it gets really heavy. Because of stuff.
Yeah, for your next step, you like to you prediction algorithm for functional status. So for that kind of outcome, this is a kind of variable and what do you want to predict?
Yeah, it's a very good question. So we're making it a categorical variable, yes. Defining it as permanent. So entering that state of severe impairment permanently. So for all subsequent assessments, they remain there. And then in terms of how we're going to predict it, we're going to use just data from the initial inter-eye assessment. And we're going to use survival models, Cox proportional, Cox models, and then predict just the hazard ratio of each individual. Then we're going to make risk groups. So assign a risk to each individual based on their individual characteristics. And then you can create however many we make, maybe make 60 risk groups within the population with increasing risk. And then you can describe the characteristics of each risk group with a survival time or a time until they enter that stage of impairment, or a probability at a certain date of having that level of impairment. So it allows us to it allows us to create numbers that we can to communicate risk in all different ways, even though the model just spits out a hazard ratio for an individual. That
So if the probability of, for example, severe.
yeah, so I think so statistically, I think like the right models is the Cox model. But then how do you once again that comes to how do you communicate this, right? What's a useful thing to communicate? And the answer is 50% of people don't understand probabilities. You say there's a 50% chance that you will be they don't understand what that means. So the most researched way to communicate these things is with iconograms. Like we have 100 people and 10 of them are shaded in at specific time points. I think the idea is that this could be information to support people in a care conference, just to support the physician at a care conference when they're talking about what the future holds. Because we have data on when someone might pass and how illness progresses, but we don't have numeric data on these states of disability.
Yeah, I think I'm not sure it's a bit challenging. I saw a lot of risk prediction models that to predict the risk, individual risk, and the infographic, as you said, is a good way to present. It's a bit informative, I think, but how to, when you have categorical variable, or you have time to, you want to predict, for example, you want to predict the time to the length of stay.
Yeah.
There is no much methodology papers how to do that.
Yeah, that's the way we've done it before is by after we make the model, take the whole population, calculate a risk for every person in the population and divide them into groups just to make cut points. Then when you do a single person score, you find out which group they fall into and you describe people in that group. The problem is, so in our testing, patients love it. You give them the time, like 1 year and 2 months. But because these survival curves, these long tails, look at the confidence intervals, and it's these huge confidence intervals, it's not really that helpful. And patients are like most non-statisticians understand a confidence interval even less than they understand a probability. So communication is always the challenge, not getting the number. We can get any number. That's not the problem, but how do you communicate it in a way that is meaningful? I think if you just shift the conversation to talk about quality of life and about longevity of life, then that's a win. That's good.
Question, can you comment on the rye completeness of the rye? Like it's supposed to be done at intake and then every 3 months.
Yeah,
What proportion of patients actually have it done every 3 months?
like almost it's really great. It's good legislated. So like our data set was like we actually set it up excluding people with incomplete cases. I think and it's excluding 2% of the cohort. So it was really complete data.
Most of the time, the question. Dan, this is great work. I think it's gonna be lots of exciting stuff. Obviously, Gina has some colleagues here in Calgary that probably great to connect with as well at some point. But yeah, join me in thanking Dan again for joining today. Great rest of the week, everyone.